And okay. All right. You guys ready for some cases? We need cases. Okay. Does everybody have their letters written in this permanent marker? Because I can't. I think I've figured out this is how we're doing it. So I think you just need 4. But yeah, if you could do it with this, then I just can't see them. They're too late. And that's my purse. That's my purse permanent marker. So I need that back. You'd be surprised at how often it's handy to have a permanent marker. Yeah. Although I pulled one out one time and they were like, "Oh, did you used to work at Starbucks?" No. I mean, I go there a lot, but I don't know. I thought it was an interesting. I don't think so. I can't remember. You're more likely to just use. Do you want another one? Here. You want me to make you one real quick? All right. So, case 1. Do you want another?
No, it's all good.
Well, I'm going to make one for you because those are too small for me to see.
Okay.
So, let me just do it because of me. It's my fault. These are called, should we do some jumping jacks?
Sorry. I looked outside and.
Oh, yes.
But then I got caught running.
The contrast. Oh. All right, case 1. Let's go for it. 53-year-old man, past history of cigarette smoking, hypertension, and hypertriglyceridemia. Vascular system's not great. Was brought to the emergency department with acute onset. Hey, this is different. This is exciting. Of decreased responsiveness and left-sided weakness. On exam, he was lethargic, arousable to voice, but required repeated stimulation. Oh yeah, does anybody else need one? Hopefully that's everybody. There you go. On exam, he was lethargic, arousable to voice, but required repeated stimulation to get a response. His pupils were 3 millimeters, constricting to 2 millimeters. So what's okay there? Sympathetic, parasympathetic. His extraocular muscle movements were full. So what's okay? 3, 4, and 6. Except for a left gaze preference and an inability to move either eye fully to the right, even with oculocephalic maneuvers. So we could do these on this guy because he's got a decreased level of consciousness. His corneal reflexes were intact. Ooh, what nerves do corneal reflex? 5 and 7. He also had left facial weakness, sparing the forehead. Holy cow. His left arm had only weak, purposeful movements, and his left leg was completely paralyzed. So, based on the patient's history, are we back in tumor country like we were yesterday? What's our vote? Commit. So we don't think it's trauma. We don't think it's a demyelinating disease. Yeah, you guys got it. Yes, we are looking at a vascular accident. He has all these risk factors. And what about that time of onset? Sudden onset. That's very typical of vascular accident. So this one you don't know, but you kind of know. So the question is, this patient has a decreased level of consciousness. Lesion to which of the following does not cause the decreased level of consciousness? So read through there, and there's a fact that you at least are familiar with. And so go ahead and commit, and then we'll see. So does a large cortical lesion cause decreased level of consciousness? Does a bilateral lesion of the thalamus do it? Pontomesencephalic reticular formation? Pontomedullary reticular formation. Which of those is not associated with decreased levels of consciousness? Oh, I know, it's a terrible question too. I try not to do that on exams. I don't ask not questions on exams. Okay, so lots of people say A, and the correct answer is D. Oh, all right. Okay, so what do we know about pontomedullary reticular formation? I think I heard it. That is respiratory arrest. So that is caudal reticular formation that is going down to the body. Yes, sir.
Respiratory arrest also causes loss of consciousness.
When you're dead, yes. But it's not going to cause you to have a decreased level of like arousal. It's how do I explain it? Well, when you stop breathing, how long do you live? Not super, right? Like a matter of minutes. So this guy, at that point, you're not going to be assessing consciousness, right? Versus this patient, we're assessing his level of consciousness. He had a decreased level of responsiveness. So he is not just ignoring us, it's hard to get through. So these other three lesions, decreased level of consciousness to the point of coma, there are three kind of different general places that can get us where basically our cortex needs to have a certain level of activity to consciously interact with the environment. So if we have issues with, we've talked rostroreticular formation, so ponto, mesencephalic, pons and midbrain, that will give us decreased levels of consciousness. So what did we hear about? What pathology did we talk about today involving cranial nerve 3 that also is associated with decreased levels of consciousness? Uncal herniation. So mediation of the temporal, or herniation of the medial temporal lobe over into where the brainstem is, right next to the midbrain. Okay, but how does this work? This rostroreticular formation wants to talk to the cortex. When you want to talk to the cortex, who do you got to go to? Thalamus. So there are thalamic nuclei that if we have a bilateral lesion to the thalamus, one of the things that will happen is we will no longer have those projections to keep the cortex awake. So we will end up with a decreased level of consciousness to the point of coma. Also, if we have large lesions of the cortex, that it can be bilateral, it can kind of be more on one side. But if we have a big cortical lesion, that's going to affect our level of consciousness because our level of consciousness is a consequence of how well our cortex is working. All right, so those are three different places where if we have people, so is decreased level of consciousness necessarily a great localizer? No, but it can be very informative when we look at it in relation to the patient's other symptoms. All right, so normal pupil size and dilation indicates what is intact. Oh, you guys are quick draws on this one. All right, we were good on that one. That was an easy one, right? Okay, so that is correct. Sympathetic and parasympathetic innervation of the pupil. Oh, I'm asking you again, which nerves mediate the corneal reflex? Okay, so that's it. That's okay. It's good to commit. Okay, that is correct. 5 and 7. And so just a review of brainstem circuitry. What is in the green here? I need to switch this over so it's on the same side. What is that nucleus that is a long nucleus that's found in lateral brainstem? No. Medial longitudinal probably isn't in lateral brainstem. It's also not a nucleus. It's a bunch of axons. So vestibular is in lateral. What's the one pictured here? You could actually look also at the bottom of the slide, would be helpful as well. Nope. Spinal trigeminal nucleus. Okay, so this is the one. That's okay. We got it eventually, right? We worked our way through painfully. So that is where pain and temperature sensation for the face that's kind of its territory in the brainstem. That nucleus is relaying that particular type of sensation. And it's a long nucleus. It goes all the way from down at the cervicomedullary junction all the way up to pons. So there's a couple different places where we can get issues with this. So what this says though, and then also, then the efferent limb arises from that facial motor nucleus. So the fact that the corneal reflex is intact tells us that all of these structures are okay. So cranial nerve 5 is okay, spinal trigeminal nucleus is okay, facial nucleus is okay, facial nerve is okay. That's why we do reflexes. That's why it's important to understand what the structures are that mediate that reflex, because if the reflex works, what does that mean? Those structures are intact. Yes, sir.
Is the green dot on the lower disc, like, if it was all the same track, would it be on the right? Or
No, I need to move it over.
Okay.
I should have just, because there's one, do you see the one on the other side? So there's one here, 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 there's one here. Like there's 2 trigeminal nerves, so there's 2 spinal trigeminal tracts. Usually I will outline one so that you can then look over on the other side and see an example of the other. And I just was inconsistent, so I apologize. I will fix that. I swear I'll fix that. In fact, I'm going to make a note. Fix spinal trigeminal nucleus, same side.
And
Okay.
when these guys are stained, the white-gray matter color is kind of inverted?
Yeah.
Like gray is
Yeah, because this is a stain for myelin.
Okay.
This is a myelin stain, so axons end up being dark, and gray matter, neuronal cell bodies aren't myelinated, so they don't show up. So it's kind of like it's a photonegative little. All right, so. But this, in terms of this patient's injury, this is telling us we're probably needing to look at something above these levels of the brainstem, right? Because we assessed these particular levels of the brainstem in terms of function, and we saw that they were okay. All right, so we just said that the facial nucleus was okay, and the facial nerve was okay. Why is that patient's face weak then? We have left facial weakness sparing the forehead. What kind of weakness is that? Okay, so I need everybody to commit. Everybody commit. Okay. All right, so that is our differential for whether or not we have an upper motor neuron versus a lower motor neuron lesion, because the corticobulbar tract, the cortical innervation of the forehead, for both sides of the forehead, the right side and the left side of the brain innervate both sides of the forehead. So if we lose one side, doesn't matter, the other side will tell the forehead to move. All right, but the bottom of the face, the right side of the brain controls the bottom of the face. The left side of the brain controls the bottom of the face. So if we've got lower face weakness, it could be a cortical lesion, could be a lesion of the facial nerve or the facial nucleus. But the forehead is our differential, right? And we talked in class about MCA stroke versus Bell's palsy. So does this person have something that looks more like MCA stroke or something that looks more like a Bell's palsy? So this would be more like, and this person just had a stroke, by the way. So we determined this was a vascular lesion. So this is consistent with a vascular lesion up above the level of the pons. So the one we know about right now is cortical stroke. Okay, so so the lower motor neurons, this tells us the lower motor neurons of the facial nucleus and nerve are intact. We talked about MCA stroke. So, and actually, any issue with this innervation above the level of the lesion is going to cause, or above the level of the facial nucleus, will spare the forehead. Okay, as long as it's above the level of the lower motor neuron, we will get this same this same upper motor neuron type weakness. So, and again, why our corneal reflex was intact is because it's sparing all that. So here's where the spinal trigeminal nucleus would be. Here's where the facial motor nucleus would be. Whatever has happened has to be up above this level. That's what the reflexes are telling us. Okay. Oh, yes, ma'am.
Last slide. Should that say lower motor neuron on lesion B? Just to
Oh my gosh, it
Okay,
should.
I was making sure.
No, that's so good. And that's a picture. I've got to fix that picture. Yeah, it is. It's the same picture is why. Man, you guys, it's purple though. It's the right color.
It is purple. That's why I was like, you know what? I think it is.
Yeah, it's right. So yeah, stuff like that, those are just typos on, that's probably bad in your lecture too. Man, so there's a ton of stuff. I'm just winning today. Win for me. Okay, let's do our, now that you saw the answer. So this patient has right lateral gaze palsy. So can't look to the right. And face, arm, and leg weakness on the left. So can this patient look toward his weakness, or is he looking away from his weakness? Oh, I know these are so hard, aren't they? It's easier when you like see the patient staring at their hemiplegia or looking away from their hemiplegia. Okay, all right, so we've all committed. Okay, and we are mostly right. So this patient is looking toward his weakness. So right lateral gaze palsy means I can't look toward my right. My weakness is on my left, so I can't look to the right. I can look towards my weakness. All right? Yes? Are we all okay? We're all there. So what do we call this? Do we call this right way eyes or do we call this wrong way eyes? All right, so the correct answer is B. Oh man, so we have some, this is a confusing one. This is another confusing one. So right way eyes, let's just think, why would we call it right way eyes? What is the patient telling us if it's right? So we're looking towards the side of the lesion, which right way eyes are associated with a cortical lesion. So the right frontal eye fields will control leftward gaze. The right motor cortex will control left face, arm, and leg. So we can't look toward the side of our body that is weak because basically it's our left abducens, our left face, our left arm, our left leg. So we can't look that way, but we can, this side of our cortex is okay, which is controlling gaze in this direction, face, body, arm. So I can look toward the side of my lesion. That is, once you're in the cortex, you're above all the sites of decussation. So we, no, this guy, so so the question is your patient lying to you or not about where their lesion is?
You said the lesion on the right side, and you can look to the right.
Nope.
No.
Yeah, you can look to the right. You can't look to the left.
I thought they had right palsy.
Yeah, you said right.
No, let's go back. Look at your thing. So he has a left gaze preference, and he has left face, arm, and leg. So is he looking towards his weakness or away from his weakness? He's looking towards his weakness. So right way eyes, that same side of your eye muscles are weak too. So you can't look toward the side of the weakness. You look toward the side of away from the weakness, because the weakness, the gaze weakness, it's left gaze weakness, left face weakness, left arm weakness, left leg weakness. So you can't look that direction. Your leftward gaze is paralyzed along with your left lower face, your left arm, your left leg, which is a cortical lesion on the right. Okay, so this person though, this person has left face weakness, left arm weakness, left leg weakness. Is his left abducens working? Yes, because he can look to the left. He has a left gaze preference. So that means he can't look to the right. So his right abducens with the other eye going along with it can't look that direction. So that means his right eye is weak with the left one going along with it because it's a gaze preference. But his body is weak on the other side. So he can look towards the weakness, right? He's still pondering. So I'll let him ponder.
Weakness is on the opposite side of the
Right.
lesion. and it
But
just
if my left lateral doesn't work, I can't look to the left.
No, he does. He specifically says he has a left gaze preference.
But if
So it is
what
stroke on
muscle's
the right side.
affected? The left lateral, right?
Yeah, it would be left abducens with the medial rectus on the opposite eye.
So if the left lateral muscle does not work, how can I look to the left?
No, it's the right.
But it's contralateral that's affected.
We don't know yet. This situation is not the cortical lesion.
Okay.
That's the
So my
secret here.
assumption is what's going on.
Yeah, you're assuming this is a cortical lesion. We're defining right way eyes and wrong way eyes. So this is wrong. This is wrong way eyes because the patient is able to look at their hemiparesis. All right, and that is if you work back anatomically what's happening, they're actually looking away from their side of their lesion. Okay, so that is what makes it wrong way eyes. So what makes it right way eyes is that they can look away from their weakness. And the reason is because their abducens circuitry is also messed up, is also weak on the same side as their body. Okay, so this is a particularly confusing concept, which is why we're doing a case on it, so we can kind of talk through it.
Wait, the abducens circuitry is opposite of the body.
So let's just take a step back.
You're not wrong. You just have to do
We just got to do rules of the game. So here's the rules of the game.
I know.
We're gonna open up the lesion rule of the game box, and we're gonna read the game rules. The game rules are: if the patient has a gaze preference toward the side of their body weakness, if they can look at what side of their body is weak, that is wrong way eyes. If they have a gaze preference away from the weakness of their body, rule says that is right way eyes.
Right, but what's affected then if it is wrong way eyes?
Well, let's do that right now. Haha. So, good question. So, wrong way eyes, there's the lesion. You've got a contralateral hemiplegia, and you have an ipsilateral lateral gaze palsy, ipsilateral gaze paralysis. So, the abducens nucleus and its circuitry to the oculomotor nucleus is paralyzed. Okay, so gaze is preserved toward the side of the hemiplegia, away from the side of the lesion. That's a cross sign that's telling you we're in the brainstem somewhere. All right, so now the question is, where is that lesion? What level of the brainstem would that be at? Which, think of where is the abducens nucleus? Where do you find the abducens nucleus? So where is abducens? So we've got oculomotor, trochlear, and abducens. So where is abducens? All right, let's see. Mostly committed. I have a couple middle row not commitments. Front row commit.
Keep doing this.
Just not commit. Oh, you have to commit. Okay, the abducens nucleus is in the pons. It's in the pons. So remember, 3 and 4 are in the midbrain, 6 is in the pons. So where does the abducens nerve come out of the brainstem? Pontomedular junction. And so the nucleus is just up a little bit higher in the pons. Okay? So wrong way eyes, right way eyes, cortical lesion. Wrong way eyes, pontine lesion. So just memorize that, rules of the game, and then you can kind of work your way back. So why does this happen? Okay, so here's the abducens nucleus. There's where the connection is between the brain and the body. All right, if we've got sometimes we can have that locked-in syndrome. This case, luckily, we don't. If we look at what's happening, this is an angiogram. So this is actually X-ray technology with dye in the vasculature. And there are the vertebral arteries coming up, and they fuse to form the basilar, but what's missing in this patient? Blood flow in the basilar artery. So does it surprise you that he has an issue? No. What surprises you is that it's not really even worse than it is. So he did have a clot in his basilar artery. There actually ended up being some stenosis that the clot really brought out, that he ended up with wrong way eyes. So he had a problem with his abducens nucleus. So let's see, what side was it? He had corneal reflexes, left facial weakness. So left. So he had a problem. His right side, he had his right abducens nucleus. So he could not look to the right. And at that level, that right side of his nervous system is still innervating the left side of the body. So he had left body weakness, and it was high enough up it was still catching the face stuff. But when we've got face, arm, and leg on the same side, that's up above the level of the facial nucleus. So he could look toward the side of his body weakness, but he couldn't look toward the side of the lesion because the nerve, remember, nerve lesions are ipsilateral. They're always ipsilateral. The right cranial nerves innervate the right face, right spinal nerves innervate the right body. Okay, so that is one of those crossed sides. So for your purposes, when you read through and you see something that says gaze preference and you see something that says hemiplegia, you go, okay, are they looking at the hemiplegia or are they looking away from the hemiplegia? If it's at the hemiplegia, that's wrong. That's so wrong. Don't stare at your deformity and your illness. Like, just be polite. Look away, right? So wrong way eyes is a sign of a pontine lesion. If you can gaze, if you are looking away from the side of your hemiplegia, that's much more polite. That's right and correct. And you're also telling your patient is saying, my lesion is over there, instead of lying to you. Yes, sir.
So when it says in the question, you're looking at the sign of your weakness, that's the hemiplegia.
Side of,
not
yeah.
Not the lesion.
Correct. And yeah. So that whenever gaze preference is actually like kind of like a treat. You're like, oh, a localizing treat. If you have a gaze preference, you're probably going to have some hemiplegia too, because those areas get affected. The motor for the body gets affected for this motor for gaze in some of the same places. So either cortex or pons. And so that's another like little gem. Yay, I can tell you if it's a cortical lesion or a pontine lesion. All right, so you just have to be able to parse out, are they looking away from their hemiplegia or are they looking toward their hemiplegia? If they're looking toward their hemiplegia, what is it? Wrong way eyes, and where is that a problem? Pons. If they are looking away from their hemiplegia, right way eyes, and that happens to be a cortical lesion, so they're actually going to be looking toward the side of their lesion. Okay, so those are rules of the game. Do you got those rules? So gaze preference, when we see gaze preference, what do we think? Yay! Because all we have to do now is go look and see what side of our body is weak. All right, and that'll tell us if we're brainstem lesion or if we're cortical lesion. Cool? Okay. All right.
The basilar artery.
Uh-huh.
Maybe I'm just thinking wrong, but how does it only affect one side?
Yeah, it's a good question. This case is actually much more complex. there was he actually started with like one-sided hemiparesis, and then that kind of resolved and it went to hemiparesis to the other side. And so it ended up, and then when they looked later, like there's this crazy stenosis. So he probably had some backfilling, like the dye stopped there, but if you think you've got those connections, that circle of Willis connection. So he probably had some blood supply coming, basically backfilling from the anterior circulation. And so apparently what was compromised was just that one side, just those to that medial part of the pons, because he didn't have any ataxia, right? Like he wasn't getting out loud. He must have still had blood supply to the lateral parts of his brainstem. He was just having these medial brainstem syndromes. So there's a lot of, because vasculature is connected, you can other stuff can kind of pick up the slack. But yeah, it's a good question. And he did actually have kind of bouncing back and forth symptoms that we skipped because we're just trying to focus on beacons. But yeah, that's totally legit question. Okay, so let's go to case 2. Maybe case 2 is shorter. Maybe it'll be easier. Okay, a 25-year-old woman with a 2-year history of multiple sclerosis has experienced relapsing and remitting episodes of weakness and sensory deficits in her extremities. So that's what MS does. 2 weeks prior to exam, she had onset of horizontal diplopia. The patient had the greatest diplopia on rightward horizontal gaze. Her left eye, so when she looks to the right, her left eye did not adduct. Oh, wait, adduct. Are we talking about lateral rectus here or medial rectus? Okay, so her left eye did not adduct past the midline, and the right eye had sustained end gaze nystagmus on abduction. Okay. So, horizontal diplopia can occur with issues with the lateral rectus, so cranial nerve 6 or the lateral rectus muscle or the medial rectus. So which one was it for this patient? Which one was causing her diplopia? Medial rectus, okay. So, I apparently got into a drawing mode here. Here's some eyeballs. Okay, so this eye cannot adduct. And then, watch this. This was entertaining to me. We've got end gaze nystagmus. Did everybody see that? Let's look at it again. Hold on. Let me go back. That was fun. I learned how to do that. So, and then nystagmus. All right. So, horizontal diplopia with nystagmus. What is that? Which of those options causes that? Okay, so I want you to think, does she have an issue with her lateral rectus? So is abducens an option here? Okay? All right, so it's helping some of you out. Okay, so we've had some changing of opinion. This is good. This is good. When you get new information, you should be able to change your mind. All right, so this is our second choice for some of us was more correct. Correct. So this is due to a lesion of that connection between the abducens nucleus and the ocular motor nucleus. So this woman had MS, which is an autoimmune disease that kills off your oligodendrocytes or hurts your oligodendrocytes. So you get demyelination in the central nervous system. So there's another reason we want to look at a connection, and we want to look at a connection inside the brainstem. So if you demyelinate this connection between the abducens nucleus and the ocular motor nucleus, that interrupts that signal for lateral gaze circuitry. So what happens is the eye on the same side has issues with that medial gaze. So that was why it was important to distinguish. We've got horizontal diplopia, but was it because of medial rectus problems or lateral rectus problems? If it's medial rectus problems, it's something to do with the ocular motor nucleus. But she didn't have any other issues with muscles innervated by ocular motor nucleus. It was just that. So then that means we're looking in that lateral gaze circuitry. She did have she did have the other eye, though, when it moved, she did have nystagmus, right? So when we have nystagmus in every situation except optokinetic nystagmus, what does that tell us? Somewhere in that vestibular circuitry. Okay, so in this case, there's lots of vestibular inputs running in that little vestibular roadway, the medial longitudinal fasciculus. So this is a lesion that happens between two nuclei, and it causes eye muscle weakness. So internuclear ophthalmoplegia is where the name comes from. All right, so what if she had had an issue, some type of demyelination? She couldn't be MS because it's peripheral, but what if she had some issue with her abducens nerve? One, would she have lateral diplopia? No. Abducens nerve, yes, it's nucleus that she wouldn't. Nerve, she would. But would she have nystagmus when she tried to look laterally? If we have a lesion of abducens nerve, do we affect vestibular circuitry at all? No, we're outside the brainstem. We're just hitting that go button to the lateral rectus. So the nystagmus is also a sign that we probably need to look into the brainstem to see this. Yes, sir?
If it was the abducens nerve, the signs of the eyes would just be reversed, but without nystagmus?
Exactly. You would have ipsilateral lateral eye movements. Yeah, baby steps. That's why we're doing this. Hopefully this helps. So her final diagnosis, she had internuclear ophthalmoplegia, INO, due to her multiple sclerosis. She was treated with steroids. Her diplopia gradually improved. Follow-up, she did better, but when they did saccade testing, her left eye still lagged a little bit behind the right eye, so she had a little bit of leftover internuclear ophthalmoplegia. Okay, next case. That was a little easier, right? Oh, and it didn't fix my handout. You guys, I just told you the answer, darn it. All right, a 63-year-old man, did you guys like that? I screwed up. A 63-year-old man was eating breakfast while on vacation with his wife when he stood up from the table and suddenly began looking only to the left and slid back down in his chair. He was unable to speak or follow commands and could not move his right arm or leg. Okay, so again, do we have a gaze preference? Yes. He can look to the left. What side is his body weak? Right. Okay, so what do we call that? Right way eyes. Okay, so say I didn't give up too much away. On exam, he was alert and agitated, but could produce no words and followed no commands. His pupils were equal and reactive to light. He had a leftward gaze preference and was unable to move either eye past midline toward the right. Facial sensation was intact, but he had weakness of the right lower face and slight deviation of the tongue to the right upon protrusion. He had a severe right hemiplegia of his arm and leg and an extensor plantar response on the right. Do you guys remember what the extensor plantar response was? There's another name for that. Babinski. Yeah, so he had a Babinski sign, and what's a Babinski sign of? Upper motor neuron lesion. Okay, which is terrible for localizing because there's a ton of places to get upper motor neuron lesions. So based on the time of onset of the patient's symptoms, what do you think is the nature of the lesion? We didn't hear anything about how horrible his vasculature was, but it did have a sudden onset. So would a tumor make this happen? No. Okay. All right, so I think we're feeling pretty firmly this is a vascular accident, so I agree. The patient has a disorder of language in which he's unable to either produce or comprehend language. Which of the following is important for language, not speech, but language? Okay, good. This is good. Good, we're feeling strong on this. Yeah, so this would be left cerebral hemisphere. So facial, that's language is on the left, attention is on the right. A lesion with like facial nucleus and nucleus ambiguous, that would cause dysarthria, so just difficulty in articulation of the words. versus this person is having a higher cortical deficit, is having an aphasia, which is a language disorder. His right cerebellar hemisphere, that was tricky, wasn't it? Cerebellum would be ataxia. So this person is not experiencing ataxia, the cerebellar vermis. What kind of ataxia? Truncal ataxia, okay? This patient had a decreased level of consciousness. Did they? No, he didn't actually. No. Oh, I think what happened is I started a case and realized I accidentally grabbed another wrong way eye case halfway through. So let's just skip that. But that's a review. That's he's okay there, I guess. This patient, though, he has he has upper motor neuron type face weakness. So what does this tell us about the location of the lesion? It has to be where? Above what? The trick is it's not quite exactly above the brainstem. It's above the facial nucleus. So above the pons. So this could actually happen with a midbrain lesion, but he's got aphasia. So where does that help us with figuring out where the problem is? Aphasia, what did we just say? It was associated with language, and language is left cortex. Okay, so and also he also had right way eyes, which also tells us what? Cortex. Okay, so yeah, look, I've got the same upper motor neuron issue. It's the same picture. So this patient also had slight deviation of the tongue to the right. So which side of the tongue is weak? That's a review from Tuesday. Right, that's right. So right tongue weakness. So this is deviating toward the side of the weakness. This guy probably has some palate droop too, but we've got some bigger fish to fry in terms of taking care of this patient. So basically anything below the level of the lesion that gets contralateral innervation is going to have a problem. So this patient has lower face weakness because that gets contralateral innervation. This patient probably has palate droop, contralateral to the lesion, and this patient also has contralateral tongue weakness, right? So this is probably a cortical lesion, and when you have a cortical lesion, that's the part of your face that has issues. All right, so this patient has paralysis of gaze in which direction? So it says he has a leftward gaze preference. He does too. Yeah, so this one is, so it says a gaze preference means the gaze is paralyzed in the other way, right? So this patient has, gaze paralysis to the right. So a leftward gaze preference means a gaze paralysis to the right. This patient has experienced weakness in his face, arm, and leg. On which side of his body? Okay, we're kind of beating the dead horse here, but we can just look at it too. So if we look at case 3, he's got weakness, so he can't look to the right. His weakness is on the right. So which of the following describes right gaze paralysis and right body paralysis? So back to the rules of the lesion game. So you are right, way eyes. Get it? Okay, so what does that tell us about localizing? We want to localize our lesion. So where is the lesion? Say, oh, somebody of you gave it away. Okay, back row, I need a commitment. That's right. So cerebral cortex is where this lesion is. So rules of the game, right way eyes are a lesion where? Cortex. And wrong way eyes are a lesion where? Pons.
Did the previous question mean to say leftward gaze?
Rightward gaze paralysis. Yep. I know. Words. So many words. The words hurt. The words hurt. So, yeah. All right. So medulla lesion wouldn't do anything to your eye muscles, right? Because that would be down below there. Okay. So here's a CT. You guys see this is a CT, very bony looking. Here's some ventricles, some holes. What's happening over here? Yee, a giant MCA stem infarct. That's maybe why he had some aphasia right there. All right, so this person, 3 days after admission, he did actually have a decreased level of consciousness. CT showed increased swelling of his left hemisphere. Treatment was unsuccessful. They do give you like mannitol and try and osmotically change what's going on in your brain. But on hospital day 4, the patient was unresponsive. Ooh, you've heard of this. Bilateral extensor posturing. So is this getting better? Mm-mm. So as per living will, the patient was extubated, given pain medication, and died the next day with family at his bedside. So that was a pretty nasty lesion. So not good. But we can see that progressed, right? It started off, he was conscious. As the swelling increased, he became less conscious, and then he got to the point where his brainstem was severely affected to have the bilateral extensor posturing. Yes, ma'am?
So what would they have done whenever he was admitted? I mean, did they do anything?
Yeah, they would have tried to decrease the swelling and manage the symptoms. Initially, when somebody comes in, you need to determine if you have if it's as close to the onset. You want to get to the hospital as soon as possible. If it's an ischemic stroke, which I was not sure, was this a? I am not sure if this was an ischemic stroke or this might have been a hemorrhagic stroke, and you can't really do anything about that. If it's a burst aneurysm, you could go in and fix it, but I don't know if that was what this. I'm not sure what the pathology of this was exactly. So mostly at this point it would be management. If it's ischemic, you can give them, again, that TPA that we talked about, that tissue plasminogen activator to bust up the clot, is the thing you can do immediately. But then the rest you would just manage symptoms. So one of the things they did is they would have given him intravenous mannitol, is the thing that they do, that basically increases the osmotic pressure of the blood to pull fluid out of the tissue to try and decrease swelling. Sometimes what they'll do, they'll go in and actually take out some of the skull, like temporarily remove the skull so that the brain can swell out and not get compressed, and then they'll try and put that skull flap back. But this wasn't looking good.
They did that to my great grandpa, and they didn't put his skull back in because they thought he was going to die, and he lived like 10 more years. And so he had a dented head.
Yeah, so he's missing his skull. And it's not always, I mean, sometimes the piece of the skull can die too, and so you're like, crap, sorry. We tried to keep it alive, but we can't really put dead skull back in your head. So
He was like 80, so he was just bald, so you could just see his.
yeah, his like,
But he was fine.
did it pulse when he was angry? Because that would be awesome.
No, I think it went back down.
Okay, guys, let's stay on track because I think cases are good. So we've got a couple more to get through. Case 4, a 54-year-old man with a history of diabetes woke one morning with horizontal diplopia that increased on gaze to the left and decreased on gaze to the right. So exam was normal except for incomplete abduction of the left eye. So his left eye cannot move laterally. What muscle/nerve is that? Abducens lateral rectus. He was able to move the left eye slightly past midline toward the left, but could not fully bury the sclera as he could with the right eye when he was looking to the right. All right, so lesions of which two structures? We had another patient with horizontal diplopia. So which two? You got to hold up two. We have to flicker if they're next to each other. But which two can cause horizontal diplopia? Okay, so before you commit to your answer, does a lesion of the abducens nucleus cause double vision? I'd say it does not. Okay, so I think we've had some changes where some people are scared to commit. Okay, so let's find out the right answer. Oh, it is the... Okay, so why abducens nucleus? What is the abducens nucleus? What do we call that? It's the lateral what center? Lateral gaze center. So it not only controls movement, lateral eye movement of the eye on the side it's on, but what does it also control? Movement of that other eye through that MLF circuitry. So if we have a lesion of abducens nucleus, which we saw in wrong way eyes, does the patient have double vision? No, because they have a lateral gaze palsy. So when we say lateral gaze palsy, we're referring to movement of both eyes, right? Maybe, okay, so, and that's that circuitry that we looked at, that's what we're talking about. So that's again why I said lateral diplopia is a very helpful localizer, because it can't even, if it's lateral, if it's something with the lateral rectus, if just one lateral rectus isn't moving, it cannot be the abducens nucleus. Because if you have a lesion of the abducens nucleus, you're going to affect movement of the eye on the other side too. It has to be something outside the brainstem. It has to be either, there's a couple options, but it's either that nerve or it's the neuromuscular junction of abducens on the lateral rectus, or sometimes the lateral rectus muscle itself can just get trapped. But we're not going to do those because we're in neuroanatomy class. So that lateral diplopia is double vision. And if in this case we determined which muscle was the problem, it was the lateral rectus. Because what about our patient with the internuclear ophthalmoplegia? Which eye muscle wasn't working for her? It was the medial rectus. So that's why this choice D is up there. Because if we've got a lesion of the medial longitudinal fasciculus, that will also cause the horizontal diplopia. What other symptom will you see with that MLF lesion? What did that girl have? She had nystagmus, because we're messing with vestibular circuitry when we mess with MLF. So we will get nystagmus, these abnormal eye movements. All right, so frontal eye fields, would that cause horizontal diplopia? Would that cause double vision, a lesion of the frontal eye fields, which we just saw on those right way eyes? Did that person have double vision? No, they had a gaze preference. Gaze refers to, conjugate gaze refers to the eyes moving together. All right, so a gaze preference, right way eyes and wrong way eyes, do not have double vision. Okay, so does a gaze preference, a person with a gaze preference, do they have double vision? No, because we're affecting movement of both eyes. Does a person with abducens palsy have double vision? Yes, because one of their eyes is not moving. Does a person with an abducens nucleus lesion have double vision? No, because that also messes with the movement of the other eyes. That messes with gaze. All right? So that's why lateral diplopia is actually another super good localizer. If you have lateral diplopia and it's the lateral rectus that's not moving, it's got to be the abducens nerve or something out at the muscle itself. If you have lateral diplopia and it's the medial rectus that's not moving, you're probably going to see nystagmus in the other eye, and you're going to call that internuclear ophthalmoplegia. Okay, so those are those are our two options for horizontal double vision. And those are our two locations that can happen. So again, structure function for localizing, rules of the game. Those are two more rules to add to your game. All right, so lateral gaze palsy due to a lesion of the medial longitudinal fasciculus produces a condition called internuclear ophthalmoplegia. What other symptom accompanies internuclear ophthalmoplegia? We just said it, so hopefully we can reinforce it. Okay, so, all right, I think we did a good job on that. And why do we get nystagmus with that? What is in that MLF? Vestibular circuitry. And whenever we mess with the vestibular system, what do we screw with? Eye movement. So we end up with nystagmus, all right? Okay, so we wouldn't have contralateral spastic hemiparesis or ipsilateral spastic hemiparesis because that's totally outside of the scope of the lesion. We wouldn't have ataxia because in that MLF, that's not cerebellar circuitry, that's vestibular circuitry. Okay, so the patient had we're back to this patient, incomplete abduction of his left eye, causing horizontal diplopia worse when he tried to look to the left. So this eye is not moving to the left. This eye is totally fine. So microvascular injury due to diabetes, bad for your nerves in general, but it can also injure your extraocular muscles. So in this case, he did have an abducens palsy due to basically too much sugar in his blood. So abducens palsy caused by microvascular disease. Went ahead and checked him out. Head CT was normal. 2-week follow-up, no change. But actually 2 months later, his diplopia had improved. So we can get kind of better and worse. 3 months after presentation, his exam was normal. He did have a little bit of transient diplopia, but mostly he ended up recovering. So just kind of left him to his own devices. Okay, case 5, 24-year-old woman with a history of pituitary adenoma suddenly developed a severe headache, left forehead and cheek numbness, and inability to move the left eye. 2 weeks before admission, she began having left frontal headaches centered around the left eye and nose. So what do we know about headaches? When they have a very specific location, like that kid with a headache in his posterior cranial fossa, his left fossa. Okay, so keep that in mind. 2 days before her first therapy session for her recurrent pituitary adenoma, she experienced horizontal diplopia. So we said sudden onset. Does this sound like a vascular lesion? No, this probably is not a vascular lesion. She was admitted and treated with steroids to reduce the swelling. The next day, however, her headache worsened and she had pain and numbness in the left cheek and forehead. Oh, pain and numbness, left cheek and forehead. Does that sound like a sensory distribution? A little bit, yeah. Fixed and dilated left pupil and left eye paralysis. Left. All right, so what do the facts that the patient has no body involvement and she has all same-sided cranial nerve symptoms? What does that tell us about the location of the lesion? We learned this lesson well, my young Padawan. Okay, is everybody going for that? Okay, so this is, yes, indeed, a lesion outside the brainstem. All right, no body involvement, all same-sided cranial nerve symptoms, lesion outside the brainstem. Yes, ma'am. So the patient has a recurrent pituitary adenoma, so tumor of her pituitary gland. Which of the following structures found near the pituitary gland are anatomically relevant in this case? What are we looking at here? So there's just one of them. Just one. Does she have any visual problems for those who have chosen A? Is she got a visual deficit? We haven't got to vision yet, so probably not. Okay, so let's see. What's our current vote? Okay, I'm more comfortable with the consensus at this point. All right, so not everybody quite got it, but cavernous sinus is what we're looking at here, which is why I put a cavernous sinus picture there. So object chiasm, yes, it's right there, but do we describe any problems with their vision? No. Posterior cerebral artery, that's just made up crap. Like, what? It's not a vascular lesion. Mammillary bodies, do we have any specific control of eye movements coming from the mammillary bodies? Not that you know of, and none that actually exist either. So cavernous sinus, why is the cavernous sinus important? Well, what is in the cavernous sinus? One, the internal carotid artery runs in before it comes up and bifurcates. But then we've got cranial nerve 6 traveling through the cavernous sinus to get to the superior orbital fissure. We have cranial nerve 4 traveling in the cavernous sinus or on the wall. We've got cranial nerve 3. Did you notice that she had complete paralysis of all of the extraocular? Okay. And then, we also have 5.1 and 5.2 associated with the cavernous sinus. Where was her sensory loss? Yeah, so her initial symptom, she had some issues with cranial nerve 6, which of these nerves is closest to where the pituitary gland would be? 6, okay, initial symptom. And then this develops into complete ophthalmoplegia. So we knock out the other 2 nerves controlling eye muscle movement. She had that dilated pupil. She had some ptosis too, didn't she? Okay, so definitely ocular motor nerve involved. And then she had a sensory loss in the ophthalmic and maxillary divisions of cranial nerve 5, all on the same side. So ordered an MRI. This is a coronal section. So this is one we haven't looked at as many of these at this point. But what is hanging down right here is the pituitary stalk. And then this region right here, there's a big old hemorrhage inside where the cavernous sinus would be. So the tumor is causing some problems. There's some vascularity to the tumor. So she did have cavernous sinus syndrome. She was operated on to remove the adenoma and the hemorrhage around it in the cavernous sinus. She did recover some of her movements the day after, and they actually didn't follow this patient because they sent her to another hospital closer to home to recover. But do we see cavernous sinus? Do we see how structure, function, that all went together? Okay, let's zip through this last case. A 48-year-old woman came to the emergency department with left eye pain and intermittent double vision. She has had left frontal and retroorbital headaches for the past 4 or 5 years. Okay. 1.5 years ago, she began to experience intermittent drooping of her left eyelid and dilation of her left pupil. What nerve does that? Ocular motor 3. Her symptoms have progressed from intermittent to continuous. So when we say progress there, do we mean that we're getting worse, or we're just getting the same symptoms more often? So they come and go, but now they're like more coming than going. And it's painful. Her pain is not relieved by up to 12 ibuprofen tablets a day. So she came to the ER. On exam, she had left ptosis. Her left pupil was 6 millimeters with no direct or consensual response, so non-responsive pupil. The left eye had limited up gaze, down gaze, and adduction, but had normal abduction. So what is okay on that eye? 6 is okay. The right eye was normal. The remainder of the cranial nerve exam was normal, and she had normal strength reflexes, coordination, and sensation in her body. So, ptosis, dilated pupil, limited up gaze, down gaze, and adduction with intact abduction indicates damage to which structure? All right, we have some firm answers here. Okay, that is correct. Ocular motor nerve. We are looking at ocular motor palsy. All right, so does this patient, there's 3 things we know for ocular motor. We've talked about uncal herniation, we've talked about painful third nerve palsy, and we've talked about diabetic neuropathy, third nerve palsy. So do you guys think this is an uncal herniation? Did she like hit her head and like slowly progressing? No, this has been happening over how many? Yeah, years. Okay, probably not bleeding in her brain. So have we heard anything about what's our differential? One of the symptoms that differentiates between painful third nerve palsy, so the aneurysm, versus the diabetic neuropathy. What is the difference there? Pain and pupil. Okay, so what is this patient? Does this patient have pain or no pain? Does it have pain? Is there pupil involved? Yes. Pupil. Oh, so what garden path does that lead us down? So, all right, so let's find out those. So what is the most likely in this patient? All right, so let's commit and consolidate some memories here. All right, so we are going to be suspicious because of this is a painful third nerve palsy that involves the pupil. We need to think of this as an aneurysm until proven otherwise. All right, so she does not have coma, hemiplegia, and a blown pupil, and this onset has nothing to do with the presentation we would see with an epidural hematoma. Diabetic neuropathy, that would be painless, that would spare the pupil. We probably would have heard something about diabetes as well, and it probably would not be like 4 or 5 years, kind of like coming and going, isn't really quite what diabetes really would look like either. All right, so painful third nerve palsy involving the pupil. So that's where your posterior communicating artery aneurysm is, or posterior communicating artery is, and then there's cranial nerve 3. So anatomically, these things are very close. This is usually the branch point where we have aneurysm when it comes off of internal carotid, because that's a really high pressure point, and so that can compress cranial nerve 3. So you treat it like an aneurysm until you prove it otherwise. Patient went imaging and she did have a PCOM aneurysm. The neurosurgeons went in and clipped the neck, opened up the dome of it, took it off. 1 week after surgery, she had nearly full left eye movements, no headache, no diplopia. She did have sustained damage to the parasympathetic portions of the nerve. All right, cases, you guys, we did them. So hopefully that helped. Hopefully we kind of worked through some pain. I feel like we learned right way eyes and wrong way eyes. Are you more comfortable with those now? So just skip the circuitry and learn the rules, and then you can go back and kind of figure out the circuitry, why the rules are right. And then understand the two causes of horizontal diplopia, and then be able to differentiate those third nerve palsies. And those are your big take-homes. Those, let's see, 1, 2, 3, 4, 5, 6, 7 things. Those 7 items are your big clinical pearls. You can make a necklace out of them.